This conference will now be recorded.
All right, so let's start again. Hi, everyone. Hi, Katie, Kim, Rhonda, Tony. Okay, so we're talking today about medication adherence or not. Just starting right from the beginning, there is a difference in the language that is used. Compliance implies according to who. It implies rule following. It implies doing what you're told. And I had said earlier that whether you're 15 or 50, nobody likes to be told what to do. It's doing what you have to do. Again, the question comes according to who. The power differential between the case manager and the client we've talked about briefly in other areas. Using this kind of language about following rules, that there's a consequence if you don't, increases that power differential and puts people on the defensive. And not just the client, but the case manager as well. And as a provider myself, within the hospital setting, it was true for me as well. And you can get yourself in a situation where all of a sudden you're going to toe with someone, and it's going to ruin the therapeutic relationship. It's going to put you at risk. It'll put them at risk. And it just kind of translates to less effective care and really lower positive results. So when we're talking about adherence, we're talking about more of a choice. Am I going to adhere to something? Am I going to stay with it? Am I going to remain with it? Am I going to stick to it? You know, just the word adhere means to fasten to or to stick to. So it's also make a connection with. If I adhere to the work ethic of the agency that I'm an employee of, that means I develop some kind of belief in it, or I connect with it, whether it's the people or the philosophy or the duties of the job. So keeping in mind the word adherence, just listening to the word, it's going to bring less defensiveness and lower that negative power differential rather than compliance. And that's been my experience. So you'll have to think about what your experience has directly been. So it does imply choice. And again, that goes back to the bottom line of self-determination. You know, the client has the energy, the will, the right to refuse any services, decisions, but there are consequences to that. There are outcomes related to that. So as long as they're informed and they do it, then it's theirs. The problem comes when people are refusing to do something or non-compliant, for lack of a better word, and they're not informed properly, because then they can't make an informed choice. So it's going to be the responsibility of the provider to make sure that all the details of the situation, including what the outcome could be, whether you adhere to something or don't, so that there's some understanding. It just evens out the playing field, and it makes it their choice truly, based on the information received. We want to make informed decisions when we make decisions. There's not many decisions that we make without knowing some facts, and so it would be expected that the clients would have the same privilege to that. So if we look at why people stay on medications, these are the most common that came up in the inpatient setting, and when I also worked in the probation and parole supervision program years ago. So this has been pretty steady for years and years. One of the top things that people say why they stay on medications is because the schedule is easy and access is easy. That's why I'm a huge believer in bubble packs. The meds are all set out. They're on one card. They're dated. And you don't have to worry about bottles. You don't have to worry about, checking the dosage every time. You still want to make sure the client knows what the medications are by sight. But the problems come too when the color of the pill changes or the shape of the pill changes. And so that goes back to really providing that information, and utilize your pharmacist and utilize the pharmacist that puts the bubble packs together. They're a great resource to talk to you and to talk to the client.
Just a question about that, Deb.
Yeah.
So with your experience working at Winnebago Mental Health, do you see that physicians try to get them on the minimum dosage, like the twice a day versus the
I
4
do.
times a day?
I do, yep. And that's the preferred, not because what's been brought to their attention too is the cost on outpatient, the cost on conditional release. They've been a lot more educated on that, as well as the accessibility of the medications. They will very readily say, let's look at this rather than this because it's $56 a pill. You know, so that's one piece of it. The other piece of it is what's going to make it easy for the case manager to teach how it's dispensed. How close is it going to be to when they left? And within 30 days of conditional release, when I was there, and that was just, I left in October, within 30 days, we would put the patient on self-meds at hopefully what is the final schedule. So it would bring it down to 2 a day, twice a day, or, you know, at most 3 times a day, very rarely 4 times a day. QID just isn't very common anymore. So yeah, does that answer your question?
Yes.
Okay, so the other thing too is preferred form is going to increase the adherence to the medication. Some people prefer an injection, despite popular belief, because it's easy. On outpatient in Outagamie County, Dr. Patel, I know, promotes injection first and foremost if it's available in injectable form. And by talking to the client about the benefits of injection, the long-standing, maintaining the level within the system, things to watch for, a lot of times they'll see the benefits of it. And it's becoming more popular. It's also becoming more standard for people under civil commitment that they're going to say, yes, you will take the injection. And if they choose not to come for the injection, that's where we go. So financially accessible. Under the conditional release program, I know a lot of financial for psych meds is not dumped onto the client, but still you look at Medicare, you look at Medicaid, you look at benefits for medication benefits, and that's going to play a role because there's co-pays just like you and I have. And some of these medications are $50 to $150 per pill. It's ridiculous. And then you look at the labs for meds like Clozaril, that's an extra cost. You know, you look at the lithium levels, that's an extra cost. So think about these things as you're going along and talk to the pharmacist, talk to the doctor about really with blood levels, if the patient is doing well, what's the minimum frequency that blood levels need to be done. You don't need to do overkill on those. So just keep that in mind. Utilize the provider, utilize the doctor, the pharmacist, use everyone you can. What I did, even though I worked in outpatient, I utilized outpatient resources like that, especially pharmacy. So the next thing too is the trust in the provider. If I don't know my psychiatrist at all, I am less likely to be confident in the medication decisions they're making for me, and that's true for us as well. Helping to educate the client about the provider with the provider is really helpful. You can say, in my experience working with Dr. Patel, but until that client is sitting in the office with Dr. Patel and Dr. Patel says, well, in my experience, that's going to hold a lot more water. Going to the appointments with the client, especially initially, and I would recommend everyone if it's possible, time-wise, I know that's hard, is really important. And not to create a 2-on-1, because a lot of times what you can do is you can go in and start the conversation, and if you don't need to be there the whole time, just say, I'm going to sit out in the lobby, or I'll wait for you. I don't really know how that works with you guys, so I don't want to go too far on that. So then advice of another, that plays a huge part in why people stay on medications. Advice of another could be from client to client. Advice from another could be from staff to client. And we talk about disclosure by staff. And often this is where a provider will talk to a patient about the benefits of medication. In my experience, it worked really well. So I would think you'd want to stay on it. And so you have to be careful about the disclosure there. Client to client, keep an eye open for that, because If I give lithium to person A and lithium in the same dose to person B, they may react very differently. And person A doesn't know that there may be a sensitivity in person B. So patients talking or clients talking to each other, it can be helpful or it can really be harmful. So try and monitor that. And if a client comes across with ideas about a medication, ask them where they got that information. That's going to be really important. So understanding the purpose of the medication. Too often, especially with new medications coming out, the purpose of the medication will be identified the very first time it's prescribed, and it really won't be talked about again, except how you're doing on the medication. So that needs to be an ongoing part of the conversation, because symptoms present differently, like we all know. There's different degrees of auditory hallucinations, there's delusional stuff, there's mood and thought. Schizoaffective disorder is a really good example. If you give somebody Prolixin for schizoaffective disorder and Prolixin for schizophrenia, that may look different because of the need to add a mood stabilizer to augment the medication for dose. So that's something to pay attention to, and to have regular conversations with the client about what the medication is for. It would be the same if we took a pill for diabetes and then all of a sudden we're switched for insulin. I may think that they both work the exact same way in my body, even though they're going after the same thing, but it could be very different. And I might forget. And then the purpose of the medication, that carries meaning in a lot of different ways. And what I mean by that is sometimes it can reinforce people stigmatizing themselves. So if I'm on an antipsychotic, a person will more readily identify themselves as psychotic when they're not doing well, which points to schizophrenia, which is one of the most stigma-attached mental illnesses that you're going to find. So when you're talking about medication with clients, talk about what the purpose is and what the symptoms are rather than the labels. They know, hopefully, what their diagnosis is. But if you continue to refer to someone as schizophrenic, bipolar, they're going to start to own that as a part of the identity. And if you think about it for ourselves as well, I'm asthmatic, I'm diabetic, it puts us at a disadvantage because it automatically puts in the assumption that there's something wrong continuously. So keep that in mind as well. If the client has insight into the needs and benefits of the medication, their investment in adhering to the medications is automatically going to go up. So it's not only helpful for us to point out the improvements and the benefits we see, but to ask the client what they notice from their subjective experience. Do you notice anything's improved, or do you notice anything is easier? Do you notice any less distress? Do you notice? But ask open-ended questions. The yes or no, you have to be really careful with that, because if I ask a client, are you feeling better? And they know that my goal is that they feel better, even if they're not, they might say, yep, I'm feeling better. And so ask the open-ended questions. Ask, how do you see the improvement? What's improving? What does it look like? And focus on the positive, focus on the benefits as you see them. That's really important. Too many times, client may say, I'm sleeping better, but I have XYZ. Okay, so you have maybe night sweats or you have dry mouth. You can deal with that, but really balance that with you're sleeping better. So this is how that will help your thinking. This is how it will help your mood. This is how it will stabilize possibly medical things, because there's so many different effects, just using that one example. If a client wants to feel better, they're going to be more adherent to their medication. If we want to feel better, we're going to adhere more strongly to medication. I would encourage you to work with your clients to look at all options with the provider. It doesn't always have to be, like Bev was saying, a pill 4 times a day. It doesn't always have to be for the rest of my life an injection or a liquid. So if you can instill some kind of hope for change toward what they want. And one thing we really have to be careful of is it's fair to ask the client and give the client what we would want ourselves. If I want proper care, the client does too. If I want the least restrictive means of, or the least invasive means of getting medication, pill versus injection, let's see how that can happen. And if it can't, let's be real clear about it and why. So on the other side of that, there are clients that don't want to feel worse. Okay, and that's different than wanting to feel better, because sometimes where they are right now is okay, because it's going to take some more time. So if I have some increased stability with regards to auditory hallucinations, and my hallucinations are less, but they're still present, I don't want them to be more. But the ultimate goal is that they're going to be less yet. So does that make sense? So not wanting to feel worse doesn't have to be from the point of being fully stable. And that's something to keep in mind, because that's a motivator. That's where the case manager and the provider can work with the client to say, okay, this is where you're at, this is where you've come, and this is where we're hopefully going to go, or this is what we're looking for further improvement. Yeah. So back to the word compliance. If a client feels like they have to take medications to avoid jail hold, appeal hold, restricted access to certain things or people, whatever the case may be, the defensiveness is going to come in, the challenging is going to come in, or the apathy is going to come in. And by apathy, I mean, well, if I have to do all this and I'm not in control, why do I care? And then you're going to have another host of problems, because then investment goes down, and investment can go down all the way across the board, but it's going to look different. It's going to look more hopeless rather than oppositional, if that makes sense. So keep that in mind. To use the consequences of not taking medication as the primary conversation rather than the benefits of taking it is going to be a game changer. It's going to change the game. If I'm told that if you don't take your medication, you're going to jail, versus I've seen when you take your medication that this and this and this go a lot better, that feels different. That conversation feels different. Does that make sense? Okay. So marketing and news have a huge impact, whether people know it or not, on a client being willing to try medication or not. There's a reason why the commercial for Lunesta has sheep and clouds and soft music and things like that. And there's a reason why even new medications for bipolar disorder, they don't show somebody in a manic state. They cite all the benefits. And so it's detached, and it's kind of like going to it's almost, I think of the Lunesta commercial and I think kind of fairy tale. The sheep are jumping over the moon, and, it's gonna work automatically. There's benefits to these medications, but that goes back to educating the client about the medication from the provider, because the take on the drug company that's trying to sell the med is going to be different than the provider who prescribes it, is going to be different from the case manager who supports it, is going to be different from the client who believes in it. Does that make sense? Okay. So if a client doesn't understand that lifestyle changes can support the success of a medication, you're going to be behind a little bit, and the client's going to be behind. So for example, excessive water drinking, toward water intoxication and flushing meds, that needs to be something that's put out there. If you're on lithium and you have an excessive sodium or salt intake, it's going to make a difference because lithium is a salt. If you're on an antipsychotic and you have a dry mouth, okay, what's going to work better, water or orange juice? Just those kind of tips can help. People think orange juice is going to be much more effective because right away you get more saliva, but you get more dry after that effect goes away. Soda, diuretic. So keeping these things in mind with regards to other changes that can help support the medications being more comfortable is important. So the other thing too is with exercise, people will often say, well, I'm on lithium or Depakote, so I gained a lot of weight. That is a true statement. I mean, weight gain is a side effect. However, movement and diet helps it be less. And that's just the bottom line. And I hate the word exercise because it implies, somebody's going to the gym and hoist an iron and, all that kind of stuff. If you use the word movement, when I walk, I move. When I lift, I move. When I cook, I move. When I, so that goes back to the language. And really, we constantly communicate with our clients. And so the language is going to be important from day one to day end. And it's a different way of talking because we're not used to that. And so that means being very mindful and intentional to hearing what's coming out of our mouths. Too often we're in a hurry, we talk fast, and if somebody says, "What did you say?" You're like, I don't remember. So that happens at home, that happens in our personal life, that happens in our work life. So it's bound to be a pattern that we've instilled in different practices. So let's look at why people stop taking medication or don't follow the prescription as written. One of the top ones, the opposite of the other, is that it takes too much effort. I have to put the meds together out of numerous bottles by myself. I have to use a pill splitter, and I have to split my meds. Think about 3-step skincare. Okay, am I more likely to wash my face every day or wash my face, use toner, use lotion, and then go on my way? Okay, if I have my medication set up in a bubble pack, I don't have to do anything. If bubble pack is not possible because sometimes there's a cost to the client, then assist the client in doing their pill boxes or have the pharmacist do it or have the nurse do it, have the community support program person do it, and do all the splitting if there's pill splitting right away and get them in there because that is just as much work as putting the toner on. So the other thing too that we referred to a little bit is that medication reinforces that an illness is present, and that's hard. I mean, that's emotionally hard. It tells me something's wrong with me. Just the word ill. If you think of illness, ill will, it means negative. Negative impact on health, negative impact on intention is ill will. So keep that in mind. So expense, of course, is a factor for anyone. If I have to take a pill 4 times a day, and so in a 30-day supply, I'm getting 120 pills, that's going to cost more than if I'm taking the pill twice a day, and for a month's supply, I have 60 pills. So that's another reason to work with the provider on the most efficient med schedule possible, not just for ease, but for most effective dosing and absorption in the body, because those all play a part. So people stop taking medication again because the advice of another. If a client says, "I took lithium and oh my God, I gained 80 pounds," I'm less likely to say, well, I want to take lithium because I heard it really helps with mood. Or I took Prolixin by injection and I got a really bad sore on my arm. I got a hard bump on my arm. I'm much less likely to think that the injection site is going to be pretty easy. Or if a client says, I didn't realize that the injection site needs to change because of the effects of the needle on the skin and this, the subcutaneous area, that's another factor. So when you think about medications, in addition to thinking about the side effects, think about the method of administration. If somebody has choking swallowing risk, you're not going to put them on pills 4 times a day. You're going to maybe supervise them when they take them if it's only available in pill form, or you're going to really look to talk to them about injectable form if it's available. So you have to pay attention to the medical indications of their condition physically and mentally. So the other thing too is the obstinance, I'm not going to take it because you told me I have to. That goes back to the language, compliance versus adherence. If I can say clearly that that person knows the outcome of taking it or not taking it, as far as the program goes, as far as supervision goes, as far as past response goes, that's going to be a game changer. So another thing too is that people are often embarrassed that they have to take medication. And so if we can reduce that, the exposure to that in any way, it would really be helpful. And that means that if a person is in a group home, maybe not having the open discussion about their medications when there's 3 other clients in the room, that's going to make a difference. The other thing too is that in talking about the medications, you have to take your medications for, when you get mad, or let's take your medications so you don't get irritable, or so that you don't, that counts too. If people don't take an antipsychotic, often there's going to be a resurgence of symptoms. But in front of other people, and even to the patient or the client, to prevent the defensiveness, if I say to them, well, I've seen that you feel better when you take your medication. If I'm in front of 3 other clients, that's going to have a lot different impact than last time you didn't take your medications, you blew at me. You blew up at me because you got so mad or so irritable. That's gonna sound different. I would just really encourage confidentiality, though. That's just as much as possible. That really is a bottom line. So, and I know it's not always easy. All right, so not understanding what the illness or the condition is, especially with more newly diagnosed clients. It goes right from day one being informed of why you're taking medication. If I say I'm prescribing you as an antipsychotic, and I'm a provider, a psychiatrist or a nurse practitioner, you better hope that person knows what psychosis is specific to them. Because psychosis can look different from person to person, and I think we've all seen that. So being informed, again, that's what that goes back to. And being informed not only about the illness itself, what is schizophrenia, but how do I exhibit those symptoms? What are my symptoms that support the diagnosis of schizophrenia? Because it's going to look different. That comes up a lot between schizophrenia and schizoaffective disorder, and it comes up a lot between bipolar 1 and bipolar 2. Because the word bipolar is loaded. The word schizophrenia is loaded, but they look different. Bipolar 1 looks different than bipolar 2. Bipolar 1 is most strongly manic. Bipolar 2 is most strongly depressed. That's going to present very differently. So keep that in mind. So denial of the need for medication as the intervention, you're going to get people who are in denial. Everybody goes through that, depending on the condition. somebody new to the illness as well, new to the diagnosis, it's going to be stronger often. Or if somebody's been stable for a long time, the denial of, I need to stay on this, that's where that comes in sometimes. Where, well, I've been doing really good, I don't need to take my medication. It's actually a very firmly planted, rational belief to the person. I've been good for this long, so I don't need the medication, I'm fixed. That's not unreasonable. That is not an unreasonable thought. And too often, we'll jump on that as providers and say, don't you realize that if you don't take this, it's going to go back to what it was? Well, that doesn't carry a lot of weight if I'm feeling really stable. So that goes back to talking to the client about what has been your experience when you're on medication, when you're not on medication, and have that conversation. Something else to remember too is I've seen it most with antipsychotics rather than mood stabilizers, but it applies to both. Each time a person gets stable on medication, goes off of medication, and then the medication is reinstituted, it can take longer to stabilize. And that's the way the system works. Too often, that's when complete med changes or washes are necessary, or considerations. So that is another factor in the benefits of staying adherent to the medication. Is that it can very well take the body longer to stabilize. And over time, as people are on medication, over time, there may be a chance that they will not stabilize again on that medication. So it's going to be necessary to look at a different one. So I think that it's important at least a couple times a year to stay informed from the provider about, are there some new options that are out? Medications are coming out all the time, and the side effect profiles are going down. The side effect profiles are changing, but the most common side effects, the profile is going down. So you need to be as informed as the client. And that's something to keep in mind. They're coming out all the time.
We see that. We see that especially when we get new nurse practitioners or sometimes even new psychiatrists, and they think, oh, we've got these really good meds. So they take somebody who's been extremely stable.
And they put them on the new ones.
They put them on the new ones, and then they deteriorate, and they deteriorate rapidly.
Yeah.
And then we go back to where we were before. And you see it time and time.
I bet you do.
Every time they get a new provider.
Yeah.
Like, oh my, I'm sure you've seen it.
And it's generational. It really is.
Yes,
It's
yes.
generational. When I left Winnebago, there were 3 patients that were still on Thorazine, which is unheard of. But they have been stable for years. And so we're going to use Thorazine, which is about $1.30 a pill, but if it works, it works. And so generationally with providers, you're going to see that a lot.
Every single time.
Yep. And so that can really be, so knowing the history of the client and having documented history of the client with the medications is huge, So the other thing too is that looking at not just the medication as the intervention, but the things like exercise. Somebody's going to probably not be as adherent on their medication if you push that other piece. You got to balance them. You got to say the medication and the movement work together. Not if your medication isn't working, well, are you moving? Things like that. So you need to balance the benefits. To make them a little more palatable. And some people aren't going to do it. We don't do it all the time. You join the gym, 12 months later, you haven't been through the door. And so just think about that. And if you talk to yourself the same way, you guys, it can really help us too. It's put your, kind of putting the rubber to the road. And it's not always easy and it's not always possible. And we're all human, and I know that. And I know I am too. And so there isn't a pie in the sky, don't get me wrong. But these are things that really do work.
Well, in some of the cases too, I think that some of our clients have the impression that getting up off the chair and just going to the bathroom is considered exercise.
Mm-hmm. And you know what? It's movement. It is movement. So you can use that especially if somebody has mobility issues. Well, I see you walk this far, let's try just a little farther. You can actually use that as a tool. And so, but I know what you mean. You know, it can go to the other extreme. Well, I do exercise. I move around the house all day. You know, so let's just work with that. You know, and really the word movement has less negative connotation than the word exercise. So.
You hear about the weight gain all the time.
Oh,
Mhm.
yeah.
But they also need to hear the fact that the weight gain doesn't have to be as significant as people say it is, because it really doesn't.
I like to say to people, look at children. They're constantly in movement.
Yep.
The body needs to move.
It does. That's how our body regenerates. That's how it heals. That's how, if we sit still, the healing process is going to be slower, just genetically and physiologically. So, so yeah, use that. So lack of understanding and education about the medication very commonly is a good reason why somebody won't take it. Or if, say, I'm working with a client and I'm misinformed about a medication, and I say, well, it really helps with X, and then all of a sudden it doesn't, then here we go. You told me it would help. The indications for the medication, the side effects of the medication, you have to know them before you start talking about them. And that is where the provider and the education from the provider, written material. If a person responds to that kind of thing, use it. Use the medication sheets. You know, and there's acceptable ones and there's not acceptable ones. You know, WebMD is the most reliable website if you want to show somebody a website for medical and psychiatric conditions.
Oh my God.
It's the go-to. It really is the go-to for education as far as websites go. Websites are, of course, are not the number one preferred. People are. But then again, I'm going to point to the pharmacist, because I don't think I've ever come across a pharmacist outside of like these ridiculously busy pharmacies like Walmart's and things like that won't take time to talk to somebody. And the psych techs, they can be really helpful as well. If you have specific questions about the medication itself, ask for a consult with the pharmacist. You're supposed to be offered one every time you pick up a medication. You're supposed to be offered a consult with a pharmacist. And so know that. You're not supposed to get a medication, whether it's new or a refill, and be able to walk out of there without having the option to talk to them.
But looking at some of those prescription sheets that they get with their medications, it'll list, you know, what it's used for, and the clients will be reading that, and all of a sudden you'll hear from the client, well, I don't have Parkinson's, or
Right.
I don't have this, why am I taking this medication?
Well, that's a great teaching opportunity to go through that sheet with the provider or with the case manager and highlight what applies to me, and use a highlighter. Because there are tons of indications for medications.
Well, that's
So-
what I said, too.
So use that as an educational tool. Highlighters are beautiful things. And so those can really be used as tools. But you have to indicate what's applicable to me. So.
But then right away they get on the defensive, because it's like, I'm not taking that medication, I don't have this, and I don't have that.
Mhm. So what if you go with them to get the medication, what if the medication sheet starts with you rather than being handed to the client right away? I mean, no, but I mean, just thinking about that. Yeah. If you go with the client to pick up the medication and there's a big sheet stapled to the bag, why don't we take that off and then make a time to sit down with it, you know, relatively quickly after the medications are received?
Well, my response usually is that, well, medications have multiple uses for different.
And they do.
I said, but ultimately, I said, if you have questions about this medication, you should talk to your case manager or your doctor.
Yeah, but a lot of clients are going to need prompting and
Oh, yeah,
assistance to do
They
that.
want that answer right here, right now.
Well, that, and many just won't ask. Because if I don't take my meds, I go to jail. Or if I don't
Right.
take my meds, you know, I'm not going to get this or that privilege. If I don't take my meds, I'm not going to be able to go into the community on the outing. You know, so think about that. Those all play a part. They all play a part. So, embarrassment, denial of condition, we talked a little bit about that. So, not understanding the purpose of the medication, again, there's that chunk of stuff that the education is absolutely necessary. What is the medication? What does it look like? What could it look like? When it changes pill color, that needs to be a discussion. What is the medication for specifically to you? What are the side effects that you should watch for, but that don't happen all the time? A lot of times if I suggest side effects, somebody's going to think automatically they have them. So you can discuss, the most common, or you can discuss the ones that you really need to look for. With lamotrigine, you really need to look for a rash. And the rash is going to appear within the first couple days, and it can be lethal. And so those are the kind of things that the provider needs to talk about, that the pharmacist needs to talk about. That's a beautiful opportunity for a consult at the pharmacy. Because I don't want to be the one to say, if you get a rash, this and this and this could happen. Who are you, a doctor? So, and that's the kind of thing that should be provided. And that's what those consults are for. And lamotrigine sticks out the biggest, because that rash, it happens fast, it happens severe. And I mean, if it's caught, it's good, but it can progress very rapidly and just some really bad results. So, back to the news and marketing, that's also a reason people will not take medication. And some of it can have to do with the actors in the commercials. Okay, if there's a housewife on the commercial that's flitting around the house and taking care of her kids or doing the dishes or putting a nice meal on the table, that's not my life. That's not my life. Is that going to give it to me? No. And so there has to be some kind of identification with how the medication is presented for me to buy into it. Okay. If the other thing too is another example to think about is if a medication is said to be for bipolar disorder and I have schizoaffective disorder, which it can be real helpful with, you better talk about what the indications are for me specifically. Because if they think it's for bipolar disorder and they have schizoaffective, without being informed, they're going to say, that's not the medication I need to take. Does that make sense? And so it goes back to education, but I cannot educate a client until I am fully educated. And if you don't know the answer, don't make one up. That's huge. Not only are you going to put the client at risk, you're going to put your relationship at risk. You're going to act outside of your scope of practice. And none of that works. None of that works or is really acceptable. So. What's that?
I got PhD, MD, RN on my forehead.
No, but I can find out from a
I
PhD.
keep telling her, just call your case manager, call April.
Do it that way.
Yeah, put it to the person
I do
that's
not have the
responsible for
answers
it.
you. Exactly.
Yeah. So get them to a person that can answer it. Yeah, absolutely. So if the client's not educated, just a final point, it's unfair and unrealistic to expect them to be fully engaged with medication. Something's going to come up. Something is going to come up. And so if the education is thorough right from the beginning, that's going to reduce the chance of that happening. And it's got to be continuous. If I hear I'm on a medication and then the dose changes, something about that is going to change in the education. But if that's not provided and then all of a sudden there's another dose change and I missed what could happen here, it's going to invalidate the experience. So the education needs to be continuous and it needs to build on itself. And that's huge. And that's how we build our education. We build one thing on from another. And that's how we expand our fund of knowledge. That's how that works. So the right to choose what we do and do not do for ourselves, whether the choices we make are in our best interest or not, the choice is ours. And the choice is going to be the client's. And, you know, there are guardians that make decisions, but you know what? Whether I have a guardian or not, I've got something that I can control. I can keep my mouth closed. I can spit out my meds. I can, you know, there's always going to be an element of choice somewhere. Even how I react to the fact that I'm told I have to take a medication, I'm going to choose that reaction. So self-determination. If somebody is non-compliant, as a case manager, it has nothing to do with me. But if I don't provide education that's going to support adherence to that medication, that's my bad. If I'm not going to involve the provider to provide the education, or someone in a supporting role that has the information, that's my bad. I'm missing that step. So you can't do it all for the client. They need to do things for themselves. Don't get me wrong. But be the advocate that can really help in the success. And isn't that a role that we have, is to be an advocate? I hope. But again, I can't make or break it for a client. You know, I can't do it for them.
I also think, though, there are people out there who do have schizophrenia, and they don't understand why they're taking the medication, despite the fact that they've been on it for a long time and they're being stable. So I can think of an example that we currently have at Berry House. So the guy with a very violent history, on Clozaril for like 6 years, that's what's, or maybe even longer than that. That's what kept him stable for the longest time. Comes to Berry, and within a very short period of time, his blood levels go low, so now we're starting to hold the Clozaril, which is making everybody more than a little bit nervous, because here's the medication that's kept him stable.
Right.
So then he decides that he's not only going to, now that he's got that medication held, maybe he doesn't have to take his other medications either. Even though there's a court order, he's got to take the medications. So we've had the conversation with him. Part of you need, you know, you're doing well when you take your medication. You need to continue to do this because that's how you do well. So we have those conversations, because what are the alternatives here if you don't take it?
Exactly.
Because the reason that you're at Berry House is because you're taking, or one of the reasons, or one of the conditions is you can stay because you're taking your medication.
And the court order needs to be a part of that conversation as well.
It is a part of that conversation. And you can do the motivational interviewing, but for what we found with this particular gentleman, because he's also a bit developmental disability there going on, so they're thinking about doing a guardianship. We had one staff person who actually charted, yes, you need to take your medication. And like a child, he's, okay. There's no
Very
discussion.
concrete.
Okay, that's concrete. He can do that. He can't have the long conversation about a lot of other things, but okay.
Yeah, absolutely. That's a great point, because cognitive level is going to determine response to education. You know, you do better when you take your medication. Okay. Likelihood of taking medication is going to go up.
Exactly.
Yeah, absolutely. That's a great point. So as far as, you know, any questions, if you guys have any questions, feel free to, you know, you can type in, we can chat that way.
I only have one other comment I'd like to make, and I'd like to go back to what you said previously about people going to those psychiatric appointments. I was at a conference with Dr. Mays, and he talked about the role of the providers with the client. And I also had the opportunity to be in a doctor's appointment with one of our clients from Berry House 2-3 weeks ago in Wapaka County. And it was a beautiful work of art. Those psychiatrists are so trained. And what they do is they zero in on that client. And they want the conversation to be between them and the client.
Yes, they do. Yeah.
They don't want the staff person being there first and foremost. And it was just a wonderful display for my client. She said everything I would have wanted to say in 5 minutes. He zeroed in on exactly. And then he turned to me and said, anything you want to add? I said, nope, what you see is what you get. It was perfect. It's all you needed to say.
And that is taking the advocacy role.
Yes.
That is taking the advocacy role. And sometimes saying less is more. Yeah, absolutely. Was that Dr. Kurzweil by chance?
No, it wasn't.
Okay, because he's a big one for the client only. Yeah, so. Okay, so if anybody else has any questions, feel free to type in. And if not, thanks for being a part of this today, and we'll see you next time.